Hey guys, so today I decided that I was going to do some short reviews over our test material and send them to you. Basically, it's just a condensed version of what the professors in the book talked about. Um, I'm really going to hit hard on the starred slides because typically that indicates that it might be on the test. So, first we're going to talk about cerebral disorders. This is basically brain tumors, but they wanted us to know the brain anatomy and function. So we're going to talk about the lobes of the brain. I'm really going to emphasize the first four because that's what was in the book. And then I will also discuss the others that Ms. Davis talked about in lecture. So the first one is our occipital lobe. It's this back part of our brain. Back here, it is visual processing and object recognition. So for example, if it was damaged, I could show this pen to my patient. They would not be able to tell me what it was, or they would tell me something completely off the wall because their object recognition is damaged. Then we have our temporal lobes. They're right here. They are in charge of hearing and language understanding. So I could say the grass is green and they would not know what I said, or they would respond inappropriately because they thought I said something else. Then we have our parietal lobe. It's at the top of our head here. It's nerve impulse processing. So pain, temperature, touch. For example, in the stroke scale, when we rub their shoulders, arms, legs, like that, that is a part of the brain that is damaged. Also, they don't interpret pain and touch appropriately. For our frontal lobe, that's right up here in the front of our brain, its main functions are motor control and decision making. So for women, this matures faster. For men, it matures slower. For teenagers that are rash and impulsive, this just has not developed yet. So if there's something wrong with it, they might be acting rash and impulsive. They might have a labile temperament, and their motor control could be affected. So those are the ones that are in the book. Now we're going to talk about the ones that Ms. Davis talked about. We have our cerebral cortex is thought processing and involuntary movement. Our cerebellum is balance, coordination, posture, and movement. So we could stand our patient up and they wouldn't be able to stay standing on their own. Or they might be able to stand, but they can't walk well because their balance and posture is not adequate. Then we have our hypothalamus. That is responsible for hunger, thirst, sleep, temperature, digestion, all the really important things to keep us moving. If this is damaged, they could be excessively hungry and thirsty, or they could be not wanting anything at all. They could be sleeping a lot or not enough, and they could be constipated or having runs of diarrhea. You know, digestion, either extreme is not good. Midbrain, we've got breathing and swallowing reflexes. So your midbrain just controls that you swallow your own saliva, you can swallow, you breathe at an appropriate rate. Pons is the motor control and sensory analysis. So I don't know how much to say about that. The thalamus is sensory and motor integration. So like when you touch something and it's too warm, you automatically jerk your hand away, even sometimes before you know that it was too warm. That is your thalamus. Pineal gland is your growth and maturity. This is activated by light. So if you lived your whole life in the dark, you would not grow and mature the way that you're supposed to. And then we have our pituitary, which is hormones and food to energy conversion. So this is really important. This is your master gland. If it's damaged, you're going to have some major hormone imbalances, and you might not be getting any energy from your food intake. And then we have your medulla oblongata. It controls your vital body functions. So your heart beating, your lungs breathing, things like that, kidneys functioning. And then it also is the source of headaches. So Now we're moving on to tumors. We have two kinds of tumors. We have primary and secondary. Primary tumors originate within the brain themselves. The most common form of primary tumors are astrocytomas. They are graded on a scale of 1 to 4, 1 and 2 being low grade and mostly recoverable, 3 and 4 being high grade and probably not a very good prognosis. Then we have our secondary ones. This is when cells from outside the body metastasize into the brain and start to cause tumors and problems. So the most common is a glioma. This actually accounts for 30% of all brain tumors. So risk factors for tumors. We have genetic. If your genes are mutated or if a deletion occurs on your tumor suppressor gene, you're more likely to have a brain tumor. Then inherited diseases, we've got neurofibromatosis and retinoblastoma. And then for environmental is mainly just vinyl chloride. It sounds like it's a small thing, but it is found on so many different things. We've got pipes, wire coating, furniture, car factories, plastic in general. So if you live close to any factories that produce that, you're probably inhaling in vinyl chloride, which can increase your risk of a brain tumor. Then we have radiation. If you have childhood cancer, you are automatically more likely to get a brain tumor later in life because of the accumulated radiation from treatment for that childhood cancer and follow-up x-rays and scans. So what are we going to do as nurses? For our patient history and assessment, we are going to assess for a headache. The specific factors of this headache is that it will be worse in the morning and better at night. That's because when they lay down, it gets worse. And then when they sit up and relieve that pressure, it begins to feel better throughout the day. And then we just go to bed, do that cycle all over again. Then it also gets worse with cough, exercise, and bending. So basically anything that's going to increase the pressure is what makes it hurt. We can have nausea and vomiting, drowsiness, visual problems such as blurred double or peripheral vision loss. This indicates a swollen optic nerve and increased intracranial pressure. Mental status changes. We can have behavior and temperamental differences. This is really common in the geriatric population. And then we can have seizures. This will look like generalized convulsions with loss of consciousness. And then we have focal. This actually only occurs in 1/3 of patients. It presents as ringing, buzzing, or hearing loss, twitches, like muscle twitches, tingles, paresthesias, or abnormal smells and tastes. There's a whole other list, but these are the ones that she covered in the PowerPoint. So, medical management of tumors, we've got chemotherapy, radiation therapy, and targeted therapy. These were not discussed very much. Basically, they affect the growth of the cancer cells at a molecular level. And then we talked about these next two pretty in depth. So we have pharmacological interventions that is basically related to glucocorticoid administration, particularly dexamethasone, which is also known as Decadron. We're going to give this to treat symptomatic cerebral edema. We're going to give an IV push bolus to get it started, and that is 10 to 20 milligrams. And then our infusion dose is 4 milligrams every 4 to 6 hours for maintenance of that. Then we have surgical management. There are 3 main purposes for surgical management. We've got decompression, reduction or removal, and biopsy. So the different kinds of surgeries, we didn't talk about these super in depth, so I'm just going to kind of like gloss over them. We have the ESBS. The biggest thing that was discussed with this surgery is that since it does enter through the nose to go into the brain, you have an increased risk of meningitis from all the bacteria buildup in the nasal passage that gets pushed through into the brain. Then we've got the craniotomy. They shave off your hair, remove a section, like make a skin flap. Then they drill bore holes and cut a section of your skull out. If that's going to need to be out for a while, they can actually insert it like in your belly so that it keeps being vascularized and stays alive, so it will grow and reattach itself to your skull when they put it back. This can treat so many things. We can do treatment of tumors, hematomas, AVMs, aneurysms, foreign objects, and skull fractures. And we use it to provide access and decompression for all of those things. So a risk of this surgery is increased swelling and infection. Obviously, you're providing access to the brain. It kind of freaks out and doesn't know what's going on. And since it's an open wound, you can have infection. And then our responsibilities as a nurse for this surgery are to make sure that we get consent signed and that the doctor has come by and explained in depth and then answer any questions that the family and patient might have. Then we have brain mapping. This is just where they use electrical stimuli to basically map your brain so that when they go into surgery, they can avoid areas for sensory, speech, and motor functions so that when you come out of brain surgery, you are less likely to have lasting deficits from damage from surgery. And the last surgery we talked about was the stereotactic radiosurgery, which we also call the gamma knife. And I don't know if you've watched Grey's, but Amelia Shepherd was looking into all these different radiation beams that would hit this one tumor for this patient. That's what this is. This is like if all of my fingers are radiation, they're going in at different points and they're focusing on one central point, which would be the tumor, and taking it out, basically. So, nursing management after any brain surgery, we are going to enhance comfort by administering codeine. And we're going to provide nutrition. We're going to get a swallow and gag reflex test to determine what kind of nutrition that we are providing, whether it be they eat orally, they have an NG tube. If they're not handling the NG tube well, maybe we can do some TPN for a minute. Anyway, and also to know that pre-surgery symptoms may continue after surgery. The brain doesn't heal quickly. So just because you remove the tumor doesn't mean the symptoms are going away immediately. Then we've got communication. Before your patient goes into surgery, you need to establish a baseline. This looks like knowing how they communicate, and then when they come out of surgery, seeing if that's still applicable. Are they sensory deprived? Do they have, are they intubated? Can they speak? What's their sedation level? Can they hear you? Do they understand? Things like that. And then for safety, we are going to know that brain surgery patients are always at fall risk, and we're going to collaborate with therapy to get them up out of bed as soon as possible. So complications from brain surgery, you've got your DVT and all the usual risks that come with that. Bed rest, leg weakness, age, all the things. But also, since it was a brain surgery, was their tumor malignant or not? Malignant tumors increase your risk. How big was their tumor? The bigger the tumor, the longer the surgery, the more your risk for DVT is increased. So I'm not going to discuss all of the interventions for DVT right here because I feel like we have beat that like a dead horse over and over and over in nursing school. So if you don't know it by now, look it up. The CSF leak, that is due to a dural tear. It will leak out their ears or their nose. It's a halo sign. That's the main indicator. So like if there's some blood leaking out of their nose and it drips onto like a fabric, it's going to be a ring of blood with a ring of like clear fluid around it. And that indicates that they do have a CSF leak. So their headache, they will have a headache, but it will also be worse while they were sitting up. And typically this heals itself. You don't really have to do much except for maintain their pain levels. Other risks are meningitis, seizures, and not satisfactory recovery. So that is cerebral disorders. I will make a second video for cerebrovascular disorders, aka stroke.